Okay. Hello, everybody, and welcome to another session of dental shadowing. Today we have Dr. Lay with us today, who is an oral and maxillofacial surgery resident. So Dr. Lay, go ahead and take it away whenever you're ready.
All right. 1 second. Thank you, everyone, or thank you, Dental Shadowing Group, for reaching out to me on Instagram about sharing my experience, or at least my background on dental school and now my current training in oral maxillofacial surgery, and give me the opportunity to share this. So I'll just make it pretty brief, very informal. From what I know, the audience is mostly pre-dental, so a lot of undergraduate or students that are maybe even younger than that, just considering whether or not dentistry or dental medicine is something they might be interested in pursuing once they're in undergraduate. So I'll just kind of talk about that, and then I'll just kind of review or go over some of the cool stuff we do in the specialty of dentistry called oral maxillofacial surgery. And then after that, I'll try to just save most of the time, hopefully, if I don't spend too much time on the PowerPoint, on questions and answers from the audience. I do know that maybe a few of you guys may be just dental students or other kind of graduate students checking in just to hear about oral maxillofacial surgery, which is also fine. But just for the purpose of this presentation, it'll be mainly kind of covering, hopefully answering dental questions for the dental prospects, and then going over some cool oral surgery stuff. So the outline, basically a quick background on me and my education, why I chose dentistry, how I prepared, and what kind of cool schools I selected. Just go over the dental specialties that are available out there. What is oral maxillofacial surgery? Why oral maxillofacial surgery? University of Alabama at Birmingham oral maxillofacial surgery, where I'm currently at in life as a resident. My memorable moments, cool cases, and then pretty much the next steps for me, and then Q&A after. So just a brief background on me. I'm born and raised in Long Beach, California, which is part of Los Angeles County. I then went to school at the University of California in Irvine, which is down in Newport Beach. Got a bachelor's degree in public health sciences. And then I went on to University of Michigan School of Dentistry out in Ann Arbor, Michigan, where I got my DDS. During that time, I did take a year off to do some research at the National Institutes of Health out in Bethesda, Maryland. And then I came on back, finished my last year of dentistry. And then after that, I applied for oral surgery and matched at the University of Alabama at Birmingham down here in the South. And for that, I'll be finishing medical school this June at Alabama, and then finishing my residency in 2024. So 3 more years. So why dentistry or dental medicine? Well, for me, I guess after high school, I really didn't know what I wanted to do, but I had some family members that were in medicine. So I decided to just do the pre-medical route. So pretty much biological sciences was my major when I started college. And I guess from there, really not knowing why I wanted to do it. I obviously didn't do too well in school. I was kind of sidetracked, moving into another place, living alone. You kind of enjoy the college life and get to be independent, and it's quite fun. So I was kind of sidetracked and distracted at a time point. So within a year or two, I figured with the way my grades and scores were going on, I wasn't really sure whether or not medicine was something for me. So, I thought about pharmacy. At one time point, it looks like during 2010, I started to volunteer at the Veteran Affairs Hospital out in Long Beach, my hometown. I actually ended up getting certified as a pharmacy technician, where I tried to find a job at that time point while I volunteered, which I didn't, and eventually get a job as a farm tech, but I just volunteered as one. And then pretty much a year before my graduation at UCI, I ended up just giving it a shot. One of my classmates in public health, his mom was a general dentist. And, I figured, pharmacy wasn't as interesting as I thought it would be. Medicine was something I kind of put in the back burner where I didn't think about it anymore. Why not give dentistry a try? So I just shadowed his mother, a general dentist out in a nearby city, not too far away, and ended up getting hired as a dental assistant. And from there, I pretty much decided to apply or study and apply for dentistry my 4th year of undergrad. So That pushed me back, I guess, 1 year's worth of applications. So instead of starting dental school in 2012 when I graduated, I ended up starting in 2013, which is fine because nowadays a lot of non-traditional students who decide what they want to do is a little later than coming straight out of high school. So I would say it's the new norm, if anything. And during that time off, I worked as a dental assistant pretty much full time. And I went on a dental mission out in Panama in 2012, which pretty much solidified my reason to do dentistry. And obviously, the 4 points down there really was my reason for doing dentistry, because the dexterity, artistry, surgery, and patient care. So, I mean, compared to medicine, dentistry is something that is very very artistic. There's a lot of artwork to it, a lot of beauty behind it, and a lot of you use your hands a lot to manipulate and make patients beautiful again, whether it be their smile or just restoring missing gaps in their mouth. And at the end of the day, it's all healthcare, so it's patient care, which is something I enjoy as a person. It's very straightforward preparation, school selection. Back then, I mean, most students nowadays, they're pretty well prepared. They go online, they can Google and search anything they want on what type of graduate programs to apply to, and you can find all of it online. Most of the stuff I have here, you guys probably know about or already heard about through other dental students or other guests that have spoke on your program. So extracurricular is very common, pre-dental school and pre-dental club at your university. I was a teaching assistant at a point in a course that's unrelated to healthcare at all, but it's more of just a teaching opportunity. Every school really looks for dental shadowing hours. I think it increases every year, but when I did it, it was a minimum of 50 hours, which is very easy to do if you just start early. Some schools that are really heavy on public health dentistry or dentistry to underserved communities have a minimum of 100 or 150. So when you do apply in the future in dentistry, make sure you look at the programs you apply to, what their requirements are. And most of the time they'll have a minimum shadowing hours. And then at the same time, obviously, I did work at the university recreation center, a little side money, as well as, experience in just learning how to manage time, learning how to work in a team environment, learning just how to, be an adult, I guess you would say. You go to work, you have the same time every day, you show up on time, you're responsible, you have duties. So I think that working at an early age really teaches anyone how to manage their time a lot better. Study materials, I can't really say much about this. Back in 2012 when I applied, it's very different now. A lot of the materials they have now are way better than what I had back then. I can think at the top of my head, I would say I used Kaplan. I don't think that was really helpful. I used, I don't know, I think they still have the perceptuability test, but I used the CrackDat Pat. So that was super helpful. Chemistry, I believe I used DAT Destroyer. That was super helpful. Bio, I used AP Bio Cliff Notes. It's a really thin book. It's helpful. And then I guess for math and English, I just used like the Kaplan book. So, but I heard you can find most of that stuff online. Nowadays, if you talk to any of the current dental students who recently got in, all of them have scored really well, and whatever they do, just do what they do. And then I guess how I selected my school back then, being a non-traditional student, applying my fourth year of undergrad and really not having the competitive scores, I would say that I pretty much applied very broadly. I applied all over the country. I applied based on the DIA guidebook, 2011 version, which was based on average scores that are accepted by those schools. So the guidebook back then, it showed average class scores. So, what are the average DET scores for academic average, science GPA, overall GPA, and then how many interviews did they give, how many interviews they accept, even had demographic data from what I can recall, like how many Caucasian, how many African-American, how many Asians, Native Americans. And that's important because if you look at, for example, a more rural or underserved school like Howard in Nashville, Tennessee, it's a more of a, African American underserved or underrepresented ethnic group that they're trying to represent or trying to recruit because of the area they live in and the people they're trying to serve. as opposed to, I don't know, like a bunch of schools in New York or a bunch of schools in Southern California. So do your research when you do that. And that's what I did when I chose. And I think I applied to about 17 schools. I did have those, the far reaching schools, like what do you call it, like those top tier schools and, dream schools I applied to, just to see if I get an interview. And then I had most of the reasonable schools based on the scores I got. Other things to consider, I would say I didn't put on here, but tuition. So how much money it costs, public versus private school, because at the end of the day, it is money. And money, dental school is very expensive. Is way more expensive than medical school. Even though I went to University of Michigan, which is a public school, I had to pay out of state tuition, which is still expensive, but not expensive private school. So there are many things to consider. Class size is important, I think. A decent size, I would say around 100 is okay. But then you also got to look at the teacher to student ratio. So I guess how many faculty members per student are there? This is important, really important for your preclinical training. So if you're in the simulation lab doing, practice procedures on mannequins, it's nice to have, say, a faculty for every 5 to 10 students rather than a faculty to 50 or 60 students. And, if you look at the smallest programs, you'll see, I don't know, 30 something students, maybe like Harvard. And then you look at one of the larger programs like New York University, NYU, they have like, I don't even know, 400 students. So when you look at those kind of things and you factor in how much money it costs and like, are you paying what you're paying? Is it worth your education that you're going to get? So there's a lot of things to consider. And then finally, location. Where for me, I'm very easy. Like I can move anywhere I want. Like I don't mind acclimating to new location. So, I mean, leaving sunny Southern California to, half a year of winter in Ann Arbor was, it was a change for the first year. It was kind of bumpy, but overall I really liked it. And it really kind of set the plane for me to be more comfortable moving further on for additional education and training in the future. I mean, I'm in the South now, so location for me is no big deal. Applied to over 17 schools. I only received 2 interviews, and my stats weren't as great. All my numbers were below average. I would say maybe my extracurriculars, time off, some experience in being a dental assistant may have helped me. But I got an interview at Roseman. I think at that time, Roseman University in South Georgia and Utah was just open for maybe 2 years. It was a fairly new school. And then university at that time, I didn't know anything about University of Michigan. I applied there and got an interview there. And then I just went there and I figured, that's crazy. This is a really good school. I don't know how I got an interview there. And it turns out I really only got one acceptance too. So I got accepted to University of Michigan. I don't know how that happened, but I'm very grateful it happened. I'm very fortunate and very lucky that that school was able to provide me with the opportunity to, receive such a phenomenal education there. Recommendations for dental school before I move on to oral surgery. Really, at this age, it's really hard to focus on school and do well. I mean, I was there, it sucked. There's a lot of really hard science and math classes and everything. It was really rough trying to, have a good time being an adult and doing well in school and staying focused. So just do your best in school, get the best grades you can. Really important in the science courses, because this is what you're going to be taking to dental school, any health related or medical related school. Get your, apply early, do everything early, plan early, complete your shadowing hours so that you can really make sure this is what you want to do. This is what you see yourself doing. And then really think about the letters of recommendation early, because being someone who've written recommendation letters for, students or people in the past, later in my training, I would say that a lot of undergraduate letters are very generic. You don't know your professors. They don't know you. You send them a resume, a CV, and they just write it based off of that. So it's hard to do, but do the best you can, maybe to go to office hours or something like that. Get good grades, and then they'll write you a good letter. But somehow, I don't know, meet them for office hours, really get to know them so they can add something genuine to your letter rec. And then obviously, if you love what you do, keep going at it, keep pushing, and keep applying. If you don't get it in the first time, that's fine. It's super competitive. There's always highly qualified applicants, but there's never enough spots. And that's in the amount of spots decrease, as you go up the ladder. So dental school, there's only a certain amount of spots. There's tons of great applicants and you just got to keep applying. And then you go into residency. even more highly qualified applicants, even less spots, and then fellowship, even more and less. So just think about it as, just keep, if it's what you really want to do, just keep going for it and keep improving your application, keep working towards it, and you will get it. And there's many people I know that applied multiple times into dental school that got in after the second, third, fourth, fifth time, in residency, up to 3, 4, 5 times. So, don't let it, bring you down. Just keep working at it and do it. So keep your head at it. So I guess I put a slide here about Michigan. So it's in Ann Arbor, Michigan. It's out in the university town of Michigan. It's known, if you were to go to Michigan, that's what it's known for. Have you been to University of Michigan, Ann Arbor? Class size is about 110. In the third year, we pick up, during my time, about 20 international trained dentists. So we pick up 20 dentists from other countries, mainly India, some from Africa, some from China or any other countries, to have them get an American dental degree. It is a public school. It's top ranked dental school in the world, depending on what ranking you go by. It's known for its football, although its football's not that good. It hasn't been good for the last few years. It's very disappointing. The dental school recently got renovated. I believe it finishing or has finished within this year or next. So that's an old image of when I was there, but it's huge now. It looks beautiful. All the clinics are new. So if anyone gets an interview, let me know what it looks like, because it should look really nice. And that is our football stadium there. It holds about, I don't know, 110, 120 something thousand people. It's a really sweet place to be. All right, so dental specialties, what is out there, and what can you go in after you finish dental school? Well, you can, when you finish your 4 years, you can just go straight into practice. You can be a general dentist. You don't. That's a good thing about this compared to medical school. Medical school, you need at least 3 years of internal medicine or family medicine before you can even practice. So general dentistry, 4 years of dental school, you pay a lot of money, but you can go out and start working right away. With that, if you want to spend 1 more year or so, you can do another year of an AEGD, or Advanced Education General Dentistry. And most of this is at from what I know, it's at the VA or something, or a place where you're doing a lot of, I would guess, more like crowns, just more general dentistry procedures to get you better, more efficient, using more modern technology like CAD/CAM imaging or CEREC crowns, like self-milling machines and stuff. Or you can go down the hospital dentistry route. This is a little different in that you are now the general dentist in a hospital. In this kind of hospital setting, patients are very sick. Most of the time, they're the sickest of the sick. These are the patients that cannot be seen or treated, at a private practice in town or in public, because they have a lot of medical problems, whether it be, developmentally delayed, or physical problems like, cerebral palsy, spinal stenosis, anything that can cause them to not be able to do even an exam without any sort of sedation. So hospital dentistry is for a very special group of students or dentists that really love taking care of and managing complex patients, and really have the patience for that. And I think that that's a great opportunity for those type of students. Everyone knows about an orthodontist. They do braces. It's a great life. Many people maybe not know about periodontists. So they're the doctors that do gum disease and gingival grafts, gum grafts. They do implants too. Oral maxillofacial surgeon, I'll talk about that. The pediatric dentist, work with little kids up to 18. Endodontist, so the specialists that work on root canals. The prosthodontist is the dentist that works on very complex restorative procedures, like long spanning bridges, really nice full mouth restorative or reconstruction with multiple bridges, multiple crowns. They do some implants too. They do really sophisticated removable dentures, partial dentures, all that stuff. So I would think of more like a expensive cosmetic dentist. Oral pathologist is basically a pathologist that looks primarily at oral pathology. So it's someone who doesn't really see patients, from what I know, but they got a lot of biopsies to interpret and read for either a surgeon or a general dentist that does biopsies. Oral radiologist is also something that's out there, but not as common as I know. There's only a few programs that have this residency, and it's basically a radiologist for the head and neck. So they're specialized in all oral pathologies using radiology and diagnoses. Dental anesthesiologist is something that's, I would say, still new. It's been out for, I don't know, maybe a decade or less. One of my classmates, he went into dental anesthesiology. I think it's a 1 or 2 year program. And that is something that is I don't know too much about how lucrative it is or how good of a career it is. It's basically an anesthesiologist that travels and provides anesthesia for either pediatric dentists, hospital dentistry, or maxillofacial surgeons in private practice office where they need someone to manage sedation. So that's something I don't know how many there are out there. It's probably not that many. And then finally, dental public health, something that's also, for a special group of students who are interested in public health care. So looking at population and population care and service. Most of these dentists end up serving in administration, serving in, maybe at Capitol Hill in DC, on administrative boards, on legislature. They're doing more of looking at access to care, finding ways to treat and provide preventative care for oral diseases in the community. I don't know too many of them that practice dentistry unless they're doing that part-time, and then part-time, maybe community care clinic or something. So what is oral maxillofacial surgery? You can find this online. This is taken at myoms.com. It's a really, broad field of surgery in the head and neck region. You can go from just regular dental implants, some extractions that, a general dentist can do. You can do third molar surgery, from simple third molars to very complex third molars, depending on their location, positioning in the mouth. We do get trained in anesthesia. So we pretty much can do what a dental anesthesiologist does, but being a surgeon, we cannot be two people at the same time. So most of the time we will manage anesthesia, but we will have a anesthesia trained staff to monitor the patients while we do the procedure. We treat many oral pathology of the head and neck, whether it be, benign or malignant, so cancer or not cancer. We treat sleep apnea, so with surgical management of sleep apnea, as well as non-surgical management, like oral appliances. We do cleft lip and palate for kids and adults. Treatment of, TMJ or joint disease and pain, oral facial pain. We do a little bit of cosmetic surgery depending on where you go. We do jaw surgery for, alignment of teeth and jaws, work with the orthodontist for that. And then we do any type of facial trauma or injury. So for oral surgery, what are the tracks? There's only two. It's either a 4-year or 6-year, and the only difference is a 6 years dual degree. You get a medical degree after. So oral surgery, you go in, you do no matter what you do 4 years, you need at least 30 months of oral maxillofacial surgery training, and those 30 months have to be with your department, and then the remainder of the 18 months for the 4-year will be rotations among multiple medical or medical surgical subspecialties at your program. So that's just every oral surgery program should have that 4-year, core. And then for the 6-year, you do up to 2 years, 24 months of medical school, depending on what program you go to. So, if you go to University of Alabama, Birmingham School of Medicine, we do 20 months of medical school, and that's only the 3rd and 4th year of medical school. If you go to University of Michigan, oral maxillofacial surgery 6-year program, I believe I don't want to be wrong, I believe a combined 1st and 2nd year medical school, and then you do year 3 and 4. So that comes out about 2 years. And then if you go to another program like UCSF or something in San Francisco, they do a little bit of like all 4 years, but it's all crammed into the 6-year program. That's the main difference. So, if you do a 4 and a 6 year, is there a difference in, fellowship opportunities? It really depends. A lot of accredited fellowship programs would recommend a 6-year or an MD degree, but some don't. So that's really up to, your research and where you want to go for your fellowship training. I personally would recommend just doing a dual degree, so your options are, more open. You can apply everywhere. Second thing, hospital privileges. Well, this just means whether or not you'll be have the ability or the privilege to operate in the hospital to which you'll be affiliated with. So this just depends on your contract when you get hired, which I'm not even at that point yet. But from what I hear, it's based on your work log. So during your residency training, how many procedures did you do as a first assist, the first resident surgeon assistant to your attending or faculty surgeon? And the number and the diversity of the procedures will provide you a resume or a case log for the hospital to review. And they can decide based on that whether or not they provide you with privileges to operate on certain patients, procedures, time, and that kind of stuff. Respect from MD colleagues. This is really I would say a region-based kind of thing. So oral maxillofacial surgery did not start as an MD integrated program. It started just as an oral surgery just after dental school. And it was, I don't know, two years after, or two additional years, and eventually 4 additional years. And then they added the med school. So if you can imagine, the older, more traditional trained doctors do not view maxillofacial surgeons as, MDs, even though we do get MDs now. But that's just how things were back then. So that's something that, it's continually changing, and I don't really see any difference. We train alongside them. We do a lot of the same things they do. And for us who have done medical school, we train alongside their medical students as well. So I don't see any difference. More knowledgeable, I wouldn't really say so, to be honest, because if we have the same core 30 months of oral maxillofacial surgery training, then we should be competent in what we do. The really only difference between programs is the number of procedures you do for each area of maxillofacial surgery. So I would say overall, everyone who graduates from a maxillofacial surgery program will be competent in the full scope of training that they should be in, and some may be stronger than others in certain categories, but everyone should have a baseline pretty good training. Scope of training, that is dependent on the program and the location. So depending on where you go, you may have a little more of something, a little less of something else. Like I said before, everyone will have pretty much a good core training of everything. Then finally, prestigious, that just goes with name. I would say that it's something for the applicant in the future to, apply and see for themselves. If you want to go to Harvard because, Harvard is Harvard versus, I don't know, a non-Harvard, non-Ivy League school, that's your decision. I don't think your decision should be based on the name, but that's my personal opinion. I think, at the end of the day, the last bullet there, just look for what you want in your training. And hope, and if it's having a big name after your training, that's perfectly fine. But I hope that wherever you want to go, even for dental school, you go there because when you interview there, you really like the people there, you like the environment, you think that you will really grow and be a very good provider in the future, whether it be a dentist or a dental specialist. And at the end of the day, you're treating patients, and a piece of paper on the wall with a school name behind it doesn't really mean anything. What they look for is the degree behind your name. And if you have a dental degree, then they trust you. So that's my opinion about that. So why oral maxillofacial surgery? Well, for me, the biggest thing is, I've said this on my personal statement. I said this in a lot of the talks I've done in the past, mentors matter. And mentors can be, to me, they can serve as guides, advisors. They can be mentors, and eventually they be your friends. And most of these people on here are from Michigan because I spent most of my time at University of Michigan. So these are the people I met at Michigan. There's a few on there from the National Institutes of Health, which I did research with. But I would say the top row are all oral maxillofacial surgeons. Some of them are retired now. The last two on the upper right are my current UAB mentors. And then the bottom row is my research mentors at the NIH in Michigan. So all of these people have really helped me choose my career path. And my career path that I want to do is academia, so academic surgery. And it's because of these people. All of them are in academic surgery. All of them are in an academic setting. Some of them are deans, some of them are chairmen, some of them are emeritus, some of them are, one of them is a clinical director of the NIDCR. So all these people have been very supportive, very helpful in guiding, my decisions on what I want to do, and really keeping me on track with, constantly being curious and becoming a better student, a better resident, a better surgeon, and a better pretty much provider for my patients. Let's just talk about University of Alabama. Okay, so aside from being in the South, which is actually not that bad, it's great down here. I mean, there's no snow except for the last 2 days, which is the polar vortex. I mean, that's very rare. But down in our program here, I would say we're a broad scope or full scope, meaning we do everything that you saw in the little diagram earlier. We cover, benign, malignant, we do pathology, we do trauma, we do, microvascular reconstructive surgery, we do everything. So I don't want to read through all that. We did 20 months of med school, like I said. And then we do pretty much 7 months of general surgery, which is on the medical surgery side of things, 4 months of general anesthesia. And then we do 1 month of pediatric anesthesia. And overall, we do, 40 months of oral surgery. So it's greater than 30 month minimum, which I think it's awesome. So that we do more of what we're trained to be in. Aside from the training, Birmingham is a great city to live in compared to about 10 years ago. The city has definitely grown. It's really booming now. The social scene, food scene, living here, it's great. It's like the number one young university or something in the country. It's crazy. So, I mean, everyone from all over the country is moving down south. Living costs are better. Birmingham's a great place to live. So it's really popping down here. I think that if anyone in the future, there's a dental school down here too. So if you're interested in applying to dental school, check out U of E. It's a great program. You'll definitely come out as a very good general dentist. A lot of the students down here, they're doing a ton of restorative dentistry. I would say compared to what I did in dental school, specifically for crowns, like crown preps and delivering crowns, they've done way more than I did. But I mean, I'm an oral surgeon now. I'm never doing a crown again. But I would say that's something that really, makes UAB really shine compared to other schools. All right, life as I guess as a resident. I did this slide when I talked about oral surgery, so I put the intern there, but I'll just start with, it varies with programs, obviously. Just like any place, the training varies based on the environment you're in, based on your faculty, based on your teachers, and based on your cohort, based on the people you train alongside with in your class. So I put a little Mario here because, as an intern, you're just a little Mario running around doing all the work and just trying to get things done and, in an efficient manner without getting yelled at, or just trying to do things as best you can, right? And over time, you'll eventually, upgrade, to a junior. You go to medical school for a couple of years here, and then upgrade to a junior or senior resident where you're more, you're more efficient. You know what you're doing. You're more competent in what you do, and then go into your last year right here, chief resident. So you're like a big Mario now. But as a first year, depending on your class size, you'll be taking call, as we call it. It just means you have a pager, and whoever any issues with the service, it goes to your page and you answer it. And for my class, we had, we take 4 per year, 4 residents for a year. So our call would be, you take it every 4 days. And then fortunately, they don't just throw you in the water and say, take care of all the patients by yourself. As a first year, that's unsafe for patient care. So we do it, but we'd have a 5th or 6th year resident as backup at home. So most of the time we'll see our patients, we'll interview them and evaluate the situation. And then we call the 5th or 6th year resident on the phone and just give them a call, tell them what's going on. And the first few times it might be a lot of hand holding, which is fine. You come out of dental school doing fillings and cavity removal, and then now you're, see someone's face cut open. You're like, oh, what do I do? So that's fine. For the first few times, you call them, and then eventually you become very comfortable in what you see, and then you start pretty much working almost independently, and you only text or call your upper level only when needed. Rotations, this stuff is just, every place has the same rotation. It covers pretty much all the areas of oral surgery, like I showed you. Typical work hours, it's a surgical service, so you're expected to work 80 plus hours a week. It's very normal. I would say that when you are in dental school and you're considering a dental specialty, look at the work hours for sure. It should be taken into consideration, especially when you have family at home, or you have other responsibilities that you like to tend to. For me, I love maxillofacial surgery. I love what my mentor is in, and 80 plus hours is fine with me. Like, it wasn't that bad. Maybe one's 120 over, that's a little too much, but definitely consider duty work hours as some per week as something to think about when you apply for residency, if you were interested. And then for any dental students that are online, obviously, check out all the surgery programs out there to see which ones you like and see which ones are interesting. So I'll just jump straight to the coolest moments, or I guess my memorable moments during residency. The photo on the right is a highly magnified artery and vein, probably the neck. It's not one of my photos I found on Google. And what this oral maxillofacial surgery, one of its components that we cover is microvascular reconstructive surgery, and it just means tiny little blood vessel surgery. So after we remove some tissue, say a patient has a jaw tumor, remove the jaw tumor, and it's so big that you have to reconstruct it with a lot of tissue. Most of the time you need a big enough tissue that has to come with the blood supply. So for example, if you reconstruct the jaw, we would take the leg bone, and along with the leg bone, you get it comes in an artery and a vein, and we got to bring it up and reconstruct the jaw with it. And then we, hook up the vessels together. So what you see on the left there is the artery. And most of the time we use a suture that's very small. It's like the size of an eyelash, and you do it under a microscope. So you do see the sutures down here for the artery. And for the vein, it's a little different. We use something a little more simpler. It's called a coupler. It makes things a lot more easy. It's 2 little plastic pieces, and you just kind of put the epithelium, epithelium, the outside portion of the vein onto it, and then you just push it together. It's a lot more simpler. So I guess my coolest moment was pretty much assisting my attending or one of my mentors doing this type of surgery under the microscope. I'm not doing it, but I'm just assisting him, holding out the artery, holding the vein, helping him clean the adventitia off the artery and vein. Other things, performing tumor resections, rather than assisting. So once you do a lot of surgeries, or you do, perform more, then, once your attending sees you do more, they feel comfortable you doing, they let you do more. So it's just like anything in life, if you work in a kitchen or something, and you assist in cooking or preparing meals, to a certain point, you're going to be doing it. So it's better to get on with it sooner and be efficient sooner rather than later when you're like about to go into a full-time job. So a lot of these cool moments are the finally the opportunity to do something that I've been assisting so many times for, and it feels great to do it yourself. Obviously with the supervision of the the faculty attending, like right there in case anything would happen. Other cool moments I'll show with the cases are obviously anyone's oral maxillofacial surgery, any resident you've seen in the past on this show or on this program, they've always showed really cool pictures of cool laceration, cool cuts on people's faces and stuff in the trauma bay. And I would say it's the same for me. It's the time that you see the craziest stuff you've never seen before during dental school, and it's worth sharing. So I guess the first one, I go straight into it, just straight up gunshot wound. Pretty funny story. I mean, he was just hanging out at the club, just trying to chat with his homies, and then I guess he heard a few shots, and he was very lucky. This just grazed right by him and pretty much missed everything. He didn't have any fractures in his bone. It's just a soft tissue avulsion. So I just threw some stitches in and sent him home. So very lucky guy. We got some lucky people we see, and then not so lucky. Next guy, facial lacerations. Most of these are from motor vehicle accidents. So he probably hit a couple glasses here and there, but most important thing about these things is just making sure you get a nice clean wound bed. So you clean everything out and you search for any pieces that might be seen on the x-ray or on the CT scan, because you don't want to be closing up stuff and leaving glass in. So for this gentleman, take a good look, clean it out, make sure it's all clean, nothing left in there, and you just suture them up. Pretty big scalp lacerations, also probably a motor vehicle accident. Most of these are, pretty deep down to the bone or down to the pericranium. It's the layer of just tissue right above the skull bone there. And for these type of wounds, it's very important to identify where the nerve is, which should be right here. Yeah, it's intact, so that's a good thing. There's one of the branches of the facial nerve, so this provides sensation to moving the upper forehead right here, the frontalis muscle. So, any wound you look at, you got to really know your anatomy. Otherwise, if you're just throwing sutures through stuff, you might be throwing it through nerves and arteries and veins and stuff. So similar with her, just clean her up and close her really well. Most of the time they heal up very nicely. Got another gunshot wound here. Very lucky guy. I guess it just hit him and stopped right in the nose, or right in the floor of the nose here. So we just put him to sleep, went fishing, and pulled out the bullet and sent him home. So very lucky guy. There's a sweet case at like 2 or 3 in the morning. This guy was hanging out at work, and he got a pipe that slid down off the rail and hit him in the head and took off a portion of his ear. Luckily for him, we were able to put it back together pretty nicely. And then it ended up actually surviving. The biggest thing with these type of injuries is once it's big enough, if you think about it, the only amount of blood supply is just right down here where it's attached. And if, there's not enough good supply through this one little area, most of the tip will actually die off for necrosis. So in his case, he came back, I guess, 2 weeks later for a follow-up, and actually a little bruised, but looked pretty well. So that was a pretty cool one. And then we go to, pathology, tumor surgery, whether it be, benign or malignant. So these are just really big, all different cases, but very big pathology. The upper left here is a really big ameloblastoma. It's a benign, aggressive tumor that takes some time to grow, but it really grows big and expands very big. And we have to get really large, far away margins because those little cells are able to jump pretty far microscopically. So you cut pretty much, does like a total mandibulectomy. We preserve the condyles, but that's what the specimen that's what the tumor looks like outside the mouth. This case is a cancer case. They had a esophageal or oral pharyngeal carcinoma or cancer. It was so invasive that I ended up having to take the throat or the esophagus, oral pharynx, along with the larynx. So the air pipe or the true vocal cords are in here, as well as the epiglottis right there. So everything had to go. In this case, I believe this was also a cancer, squamous cell carcinoma of the upper jaw, but it was invasive to a point where we had to take his whole maxilla, including the nose, so the nasal perineum. Yeah, that's right. And then the zygoma. So I took pretty much their whole mid face. And this is just a tongue cancer. So this is what it usually looks like. There's a hole. And then we either, if it's big enough, we'll fill it with something. If it's not big enough, we'll just close it on itself. And then obviously we have fancy stuff like computer aided reconstructive surgery. This was a case we submitted and published on a resident log called OMSNIC, which is I think a group that provides malpractice insurance for our specialty. But it's just a case of another ameloblastoma of the mandible, where we use computer aided virtual surgical planning using CT guided imaging to make predictive cuts where the mandible should be. And then they print out, or they make titanium guides. So it makes the cuts easier in the surgery. And then they plan out a fibula right here. There's a fibula bone brought into the jaw. So this is the mandible cut out. This is the fibula bone from the leg bent with a plate on it. And then this hanging off it is the blood and the vein and artery, which is going to hook up in the neck later. So bring that all into the jaw and put it up there. And then here's the after x-ray. And then for these type of patients with non-cancer, we can put dental implants in the future. Once the bone's all nice and healing, put a couple implants, one here, maybe two here, and then get a nice, really big fixed prosthodontic or really nice big partial denture right here. And then when they smile, they look just like normal. Here's another computer-aided reconstruction that we did and published in another journal recently. This is the lady that underwent jaw surgery, but she had a very rare complication where her upper jaw pretty much necrosed. So we had to remove the dead upper jawbone, and what we did was use her leg bone, cut into 3 pieces of shape, and create her upper jaw. And like I said, they planned dental implants in the upper as well. So she ended up getting a whole new set of teeth, an upper jaw made of her leg bone, and she's now doing great. Here's another case, just skin cancer, some cancer stuff here, lip cancer, which is pretty common, where this is just using local flaps. So not using fancy big soft tissue stuff, but using what we have in the area and doing fancy little designs. And this is just a design that one of my mentors used that was described a long time ago, and we just brought it back. It was called a Bandonian flap, like the Bandonian instrument, where we make zigzag lines and we just pull it right towards each other, and it closes up and heals up really nicely. And then finally, we do we also do implants. So we place for patients with huge resections of the mid face, probably due to basal cell or some sort of skin cancer. When the resection is so big that's missing it, a lot of key structures like the nose and the upper jaw, it's very hard to put tissue up here that would look anything like a real nose. So, you got to decide, can this patient undergo multiple different surgeries of putting tissue up here and having a nose that's subpar, that doesn't look real, that looks like, someone did a lot of surgery on, or is it better to place implants and work with our maxillofacial prosthodontist? I forgot, that's another specialty. That's a specialty of prosthodontics. You do prosthodontics and you do maxillofacial prosthodontics. So this is a person who creates fancy silicone prostheses for the head and neck complex. The guy who works with Dr. Case, he also does ears, eyes, mid-face, he does dentures, everything. But this is basically an upper denture that magnetically attaches to his mid-face nose prosthesis, which is really cool. And this is also published in one of these journals that's open for, it's free access. Oh, and then finally, the bread, as we call the bread and butter stuff. So this is wisdom teeth. Everyone has them. The only reason I posted this case was this is the case I did my first year, and this patient had seven wisdom teeth, which is pretty cool. So we had 2 up here, 2 here, 2 here, and 1 here. So that was interesting case. All right, so for me, what's next? Well, as you can see from all my talk and my cases, there's a lot of cancer and a lot of big tumors. So, I'm interested in head and neck oncology and microvascular reconstructive surgery. This is what I want to go into. It'll be another 1 to 2 years, depending on where I go. There is a fellowship application, just like dental school and residency is a different application for fellowship. But I'm looking at, either stay here at UAB, maybe go back to Michigan, maybe look at Florida, maybe go to Texas once the snow melts, maybe Miami, Portland, I don't know. But it'll be, a year or 2 in one of these areas. And then after that, I'm interested in hopefully just staying at an academic institution, a hospital where there's medical school and a dental school to work with. as well as a team of faculty to work with. So that could be either at UAB, it could be in New Orleans, it can be somewhere in Texas. Ultimately, I like to, work as a head and neck surgeon in a head and neck practice, do research, and participate in resident and dental student training. So this is a short slide. If you're interested in oral surgery for the dental students out there, or for the pre-dental students, if you're pre-dental and interested in oral surgery, obviously get your shadowing hours for your general dentist first, because I think that's a primary requirement. You need to shadow a general dentist and not a specialist. And after each minimum hours, then you can shadow an oral surgeon, see what they're doing, and see if you're interested. And most of the time when you shadow an oral surgeon, it's a private practice. So you're not going to be seeing gigantic tumor resections or some crazy big surgery. A lot of it will be, the wisdom teeth, bone grafting, sinus lift, some stuff that are pretty cool too. But you're not going to be standing in the operating room for like 10 hours straight. For current early dental students, first and second year dental students who are here or will be watching later, shadowing your oral surgery clinic at your school, as well as the hospital, if they have the ability to do that, check it out in the clinic at the school, the clinic at the hospital, as well as scrubbing the OR. And for third and fourth year students who are planning to apply for oral surgery residency this spring, school, anything you're applying to is all about grades. Study hard for the exam, CBSE, everyone knows about. Maintain a competitive GPA, do the best you can. But when you go to dental school, that, in order to apply for dental school, you can score really well and kind of be like the top 10 percentile of all the applicants. But once you go to dental school, everyone there is top 10. So now you're competing to be top 10 out of all the top 10s in the country. So it'll be very hard. In that case, just have a competitive GPA. So you can be ranked 20 out of 100 students and still have a 3.9. That's just how it is. So make sure you have a good GPA and, good rank in your class, do well in your exam, be involved and take on leadership roles in many organizations. This actually goes for anything. So, even when you're applying dental school, sometimes it's better to participate and take leadership roles in a few organizations that you really truly care about than just be a member of like 15 organizations where all you do is attend meetings. It looks cool on paper, but once you get interviewed and they ask you about it, you're not going to really say much. You're like, well, they did this, they did that, but what did you do? And then, if you're in dental school or in undergrad, be involved in some sort of scholarly activity. For me, it was research. For other people, it might be volunteerism. It might be community service. It might be teaching assistant or tutoring. And then finally, for those dental students, extern. So right now with COVID, it's impossible to visit because of restrictions. But once things go back to hopefully the normal, maybe in the late fall or late summer, visit where you want to go. And even for dental schools, I think that if you're in an area where there's dental school within driving distance, I think it's worth visiting to see what the school is like, maybe even to meet up with some students. Finally, I think, advice, I would say, stay curious, be motivated, stay focused, focus on being better every day, improve every day, and be a lifelong learner. Dentistry, it's a long field. It's only another 4 years, not bad compared to adding 6 more for oral surgery, but anything after undergrad, additional 4 years is a lot. So, if you continually work on becoming better every day, then you'll get there. So success, people think it's a straight line, but everyone knows once you go through it, it's all over the place. You're just going but your goal is to go upwards. Okay. So even for me personally in undergrad, my scores were, but if I looked at my trend, as they say, the trend is upward. So at some point you drop, or I dropped, and I realized what I want to do, and it went up. So overall, it might look, like whatever, not competitive. But if you look at the trends at the near end of an applicant's, application, they see that there's a general trend toward upward. They're doing well, and they're doing all these additional extracurricular activities and being more focused, great rec letters, good shadowing hours. And I think that it makes for a good argument that this person or applicant is more dedicated to what they want to do. So with that, I'll end it there, and I'll just leave it on the slide for questions.
All right, so we have a few questions in the chat. The first one was, any advice for international dentists interested in OMFS?
That is a great question. I know one of my good friends. He's an international dentist. He's a good friend that was a classmate at University of Michigan. I would say he's currently in oral surgery program at University of Maryland. He's in the 4-year program there. He's also interested in doing medical school, which is from what I know, very tough because medical schools in the United States need a transcript, prerequisite courses from undergraduate credits from the United States. So, what I've told people is the best thing to do is to look specifically once you get into a dental school that has an international training dental program. Once you get there, which is also very challenging. I heard it's super competitive. But once you get in, look into the oral surgery programs if you're interested in the MD program. Look into the medical schools at their requirement. And this will help you a lot in that in the future, when you do apply for oral surgery as an international student, you're not wasting last minute time and money on a program that you're going to pay for an application. They immediately reject you because they say, you're international, you don't have transcripts from a, prereqs from a United States program. So sorry. If you don't want to do a 6-year program with a medical school, then I think it's possible. There are, from what I know, there are a good amount. I have a couple friends that are international trained. One from Chile, he's currently in Howard University right now. The one in Maryland, there's a couple. Most of the time it's a little bit challenging at first. Most of them may not get in right away, just like dental school. They don't match right away, but they get a non-categorical position. It's basically you're an intern, but you're with all the same duties and responsibilities, but you're not in the program. So you're part of the team, but you're also reapplying next year. And this doesn't mean that you're wasting a year. This actually helps you. So, best case scenario, you're a dentist in another country. You come over here, you apply for the super competitive international dental program. You get in, wonderful. You do great in school, right? You're already smart. You know everything. You just get straight A's and you're top of your class. That's what most of the international dental students, dentists that I meet are, and they're great with patients. The only issue is language barrier, which is it's as expected. So most of them do just fine. And then they apply to oral surgery residency, and then some of them get in right away, they match, and then some of them have to do this non-categorical year, which is fine. Then most of the time after that, with 1 year under their belt of being an intern, when they apply again, I would say most of the time they do match. So it's more of you've spent a lot of time in training already, and you come in the United States to do something that's also going to be, a long road. But I think at the end of the day, if you were to look at it, it's possible. It's not, oral surgery is a long route. So if you spend 2 years in America for dental degree and then you do another 4, I don't think it's that bad. It's not another 10 years. So it's definitely doable, but definitely look it up. I say the first biggest barrier is just getting into a dental school that has, the program for you.
And then the next question was pertaining to how long. So I guess from the start of your undergrad all the way until you finish your fellowship, how many years of school will that be?
Oh, okay. Well, I'm going to say based on if I had a traditional route without any gaps here or there. So, I graduated high school is when you're 18. Undergrad is 4 years. Dental school is 4 years. Oral surgery is minimum 4 years, unless you do the MD route, so 6. So it is 4 plus 4 plus 6, 14 years. For me, I already said I decided dentistry my last year, so that's an extra year there. So it's 14, whatever, 8 plus 6, 14 plus 1, 15. And I took a research year, so 16 for me. And then, obviously after the oral surgery, I want to do fellowship, so plus 1 or 2 more. So then you're looking at, I don't know, I don't count anymore after that. It's just pretty much once you finish dentistry, I see it as you're working. In dental school, you're in class, you're doing lecture, you're taking tests, you're in the sim lab, you're drilling on mannequins, typodonts, you're constantly getting graded, evaluated, and reviewed. But then once you graduate dental school, you are a licensed dentist. You are a practicing dentist, learning more of your subspecialty, but you have a license. You should have a DEA number to prescribe medication. You are treating patients. So I wouldn't consider that school. I would consider that training, or you're working. So it's all how you see things. Now for oral surgery, if you're doing 4 additional years of residency, you are getting paid. You're getting paid, you're working, you're treating patients, but you're learning as you're treating patients. So that's working. The hours are crazy, but you're working. But if you're doing an MD program, yeah, you have those 2 years of being a medical student. Yeah, that's a student, but the other 4 years are still working. So.
Okay, cool. And then someone had a question about some of the transplants. So when you use a bone from the leg to do a reconstructive surgery, what exactly is happening to the leg? Is part of the bone just removed? What is entailed in the healing process?
Great question. I wonder if I have a photo of that. So basically, when we take the leg bone, we take the fibula bone, which is a smaller leg bone of the leg. And in the leg, most of the weight bearing, over 90% of your weight bearing is in the tibia, the larger bone. The fibula bone is just there for at the proximal or the knee portion and the distal, the ankle portion for ankle support, as well as for, I guess, knee support, knee stability. So when we take this bone out, we take only a portion of the about 6 centimeters from the knee and 6 centimeters from the ankle. Can you see that?
No, we're not able to see it.
Huh, I'm on this. Let's see. Try something here. I'm gonna try to reshare it. Can you see it now?
Yeah, we're able to see it now.
Okay, cool. So this is a fibula that when I was in Michigan that we took. And as you can see up here, this is where the knee is, and this is where the ankle is down here. And it's at least 6 or 7 centimeters away. And the reason why we keep this up here that far away is because there's a lot of very important blood vessels and nerves that come out right here. So we don't want to dissect anywhere far up or cut anywhere where I nick something very important up here that provides blood supply to the rest of the leg. Down here where the ankle is, we keep at least 6 centimeters away so we can get ankle stability. Now, after the surgery, the patients will do just fine. We put on a rigid boot. It's a black orthotics boot just to keep the ankle stable and the patient comfortable. Over time, this will not really move. These two bones will just heal the way it is because there's a lot of tendons and ligaments that keep the bone where it is. It's not just going to flip and flop around, as well as the calf muscle and the other muscles in the leg that keep everything intact. And over time, unless this patient is a competitive tennis player, competitive soccer player, an MMA fighter where they kick people all the time, they go back to their lives normally. Some of the patients we have that I've seen in the clinic, they go back to regular jogging, regular biking. I wouldn't say competitive marathon running, but daily activities are just fine. And they'll have a small little skin scar down here where we take the skin and put it in the mouth. And this is just a drain, so this gets removed. And these are staples. So this is what usually the leg looks like. We keep a portion of the top and the bottom.
Awesome. And then another question that someone had was, what was the most intense surgery you've observed or assisted?
Well, I would have to say the longest one I've been in was the one also at Michigan. It was when I was a student. It went from first case. So first case means the beginning of the day. So, you're in the room around 7 a.m., but anesthesia and everything, you don't start till 7:30, 7:45. And we were in there till I think midnight. And that was because it was a patient that was really sick. He had cancer, but it was recurrent cancer. It was cancer that was previously treated in the mouth by surgery, and then it was treated with radiation. I don't think he had chemo. He treated radiation to the area to decrease the likelihood for recurrence. Unfortunately, over the years, I think within 2 years, he had recurrence or residual disease. And usually when cancer is resistant to radiation, it comes back way worse. Prognosis drops down real low. Patients don't survive for that long. So now you have a really sick patient who has cancer that persisted recurrent in the same area we operate in, the same area we did radiation in an area that you put soft tissue in that's now irradiated and it's all jaggedy. And if you can imagine anything getting blasted with radiation, the tissues they're not good at all. They're scarred down, they're fibrous, they're easily friable, it just falls apart. So now you're working on removing additional cancer, making a bigger hole in an area that doesn't heal. And in those cases, you got to look at, well, if we used a forearm skin or flap or a leg bone to create what we fixed in the past, we can't really do that again because now you're using, is it dependable? What if we put it up there and then you put a nice soft tissue in there or hard tissue in there and in a poor wound bed doesn't heal? So now you just took something from a patient that, you shouldn't have done. So for those type of surgery, we tend to look for something nearby. So in that case, if I can remember correctly, we did a regional flap. So I think we took a latissimus, the back muscle and skin, and try to rotate it up. or maybe even try to do a free flat up there. It's more dependable vessels. Anyway, I went up there and the blood vessels were horrible. There's a lot of calcium in it. They couldn't get good flow even after you connect them for multiple hours. And there's a time limit when you bring soft tissue up, and there's a limited time to how long the tissue cannot have blood, be ischemic. And once you hit 4 hours, which we were at, and we're not able to get adequate blood supply, that's when the flap starts dying. Okay, so once it dies, you got to throw your hands up. You lost it. You got to throw that away. So now you just harvested a big hunk of tissue, created a hole in someone's back, and you got to throw it away. So now we got to close that, which is fine. But now you got to think of something else. It's like 10 o'clock on 10:30 p.m. And now you're looking at, you still have a big hole in their face, and you got to look for a last minute, a different option. And you don't have time to pull another back area out. That's going to be another 4 or 5 hours, and you're not going to be operating until 3 a.m. So in that case, I think they just went for a simple temporal fascial parietal flap. So something from the side of the head, and they just brought it down. No separation of the blood vessels. They just brought it down, swung it down just to fill the defect. In those cases, obviously, you're looking at, we're not looking at optimal aesthetics. You're looking at about just filling the defects. So hopefully to let them heal. So in that case, that took forever. But, by the end of the night, long day, tired legs. I don't even think I wanted to walk home after that. But, everyone was tired. But it was a memorable moment. It was with a lot of really good friends. It was actually with Dr. Hellman right here, one of my very good mentors. He was the attending, and actually Dr. Justine Mel right here. She was our fellow at that time. This was back in 2017. So that was a long day, but those memorable nights.
Another question was, with an 80-hour work week, how do you juggle your other activities? Any advice for self-care during all of this?
Oh, great question. For me, my self-care is weight training and going to the gym. I guess my only advice is, if you have a hobby that you really like, you will make time for it. Well, obviously it depends on what the hobby is. You can't go, I don't know, shooting hoops in the middle of the night at 2 a.m. But for me, weight training, going to the gym is straightforward as long as you can find yourself a 24-hour gym. Obviously, your first year of residency in oral surgery, this is all oral surgery, because for dental school, it's way more reasonable. Dentistry, you're studying all the time, but if you can sleep at reasonable hours and wake up and go to school and still be fine. It's stressful and everything. But for oral maxillofacial surgery, the first year is the worst year. So a lot of residents, they sacrifice or they put their hobbies and social life on hold for a year. It's very common. It's not uncommon to do that. It's a stressful time during the year. There's a high rate of burnout. But coming in, knowing that ahead of time really helps one prepare for how to manage it or how to decrease the likelihood of it. So luckily for me, fortunately my circadian rhythm or my sleep schedule has always been since high school. I'm up really early. So it's really easy for me to go to the gym at 5 a.m. It's normal. And it's really easy for me to go to bed before 9, as early as 7:30 if I need to. So intern year, obviously I didn't go to the gym every day, maybe a few times a week. That's fine. I'm working most of the time. But once you get back on, after you deal with the big hurdle during the first year, after that, it's pretty much, I would say, a regular work schedule, because mainly at our program. Our program is front loaded, as we call it. The first year is, the busiest year. And then after that, it gets better every year. And other programs may be evenly spread out. So that's something for applicants in the future to really talk about during the interviews. Like, how is your call schedule? What is it like here? And that's something separate. But I think that time management is something you'll learn during dental school. And you can definitely bring that into residency, because dental school is busy. It is busy. You have to study for didactic lectures, PowerPoints all day. And then you have to go to the lab and drill on a mannequin all day. And then you have an exam that's written, and then you got to do an exam like filling a tooth or prepping a tooth. That's horrible. That's a lot of stress. And a lot of students, not everyone is naturally talented with their hands where they just come in and do 2 preps and it's perfect. I was an average student. Like I drew like a ton of preps before it became decent to be comfortable for me to take it. So I think dental school really prepares every dentist to be very good at time management if they graduate and do well. So that's a very good way to take that mindset into this type of residency where you're expected to manage a ton of things at once. It might even be more than what you did in dental school, but at least you know how to do it.
And then what advice would you give to your younger self?
Um, I mean, if I would go back, I would focus more. I mean, dental's pre-dental. I mean, I would do better in school. Obviously, I'd focus more. I mean, that's a very common question everyone asks everyone else. I think at the end of the day, people say, I want to go back. I wish I studied better. I wish I focused on this better. But I'm very happy where I'm at today. A lot of the things I did, I learned from. And a lot of these people that I've shown on the photos, like I wouldn't have met if I was in my room studying all day. Um, I spent a lot of time during dental school, like not being in dental school. I was in the OR. Like most of these Michigan people know, or my attendings and mentors know that I shadowed real early. I was in the OR my first year of dental school, and I kept coming back. It's like sometimes, I mean, I kind of regret it. Some classes where it's like super boring. I'm like, I don't really want to go to lecture. I'll read it later and I'll go to the OR or something because I just really love being around these people. It's really something I really love. So it really depends, but I think that relationships, mentors are built through time. And there's almost so much time in the day, and you can spend it studying and doing better in school, which is very important. And I do not want to downplay that. But for me, I spent it a lot with for research. I spent a lot in the research lab doing a lot of research with my mentor, spending a lot at the hospital in the operating room. I try to go to lunch at least once a week or once a month with some of my mentors at the dental school. I'm always in the clinic or OR, so like I'm the guy that's just always around. So I mean that's what I did. But yeah, if I were to go back, I wish I would have got better scores here or there. I mean, I think a better GPA, a better rank, a better CBSE score, all of that would make my application better. But would that have made my letters worse? Would that have made my years of getting to know these people worse? Would it have made like, the time you spend around these people, it really changes the way these recommendation letters are written too, and really opens doors to other opportunities. Just to briefly talk, like I mean, I got into the NIH program because like my research mentors at Michigan knew the 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 PIs or the investigators at the NIDCR or the National Institutes of Dental and Craniofacial Research. And then my mentor, Dr. Feinberg down here, he knew my research mentor that I ended up working with at NIDCR, Janice Lee, personally. So I mean, if I didn't know these people when I was studying all day, I don't know if there's a lot of things I would have been here today. Most of these were just all networking, to be honest. And I really wouldn't have changed anything.
And then another question was, in an emergency situation where a reconstructive surgery has to be performed and the patient is unconscious, who makes the decision to take part of the leg or a rib for the procedure?
It's a very interesting question. I don't know if it was worded correctly. Maybe I think they're trying to say, I'm gonna think of a situation similar to that. This doesn't happen often. Only thing I can think of is maybe trauma, maybe, because most of the time, late stage oral cancer, they come in, they already have a big tumor. It's got to go. We usually expedite, medical insurance coverage, and planning with radiation or medical oncology if needed, and then getting necessary imaging to make sure that they can handle the procedure. That's different. They're not unconscious. Trauma, I guess, someone comes in, maybe I've seen this. Some girls gets her jaw kicked by a horse and half her jaw falls off and it dies or whatever. In those cases, I wouldn't consider it an emergency to get a leg bone reconstructed. Most trauma can be delayed. The only urgent traumas for reconstructive surgeons that we know of, that we don't do, head and neck surgeons don't do, would be, hand service or limb service, which is covered by orthopedics or plastics and reconstructive surgeries. So if someone comes with an amputated limb, finger, hand, upper limb, lower limb, they have a certain amount of time that they go to the OR to reestablish perfusion or get blood supply to that. We don't do that. And we don't reconnect heads either, because that doesn't happen. So in oral maxillofacial surgery, I don't think we ever run into that. If we ever have any issues with urgent reconstruction where someone's incapable to make the decision to have the procedure, we have a family member. So the person we go to is the next of kin or the person who's in charge of making a medical decision to decide on that. But the majority of our cases for cancer that need a reconstruction that big, that we have multiple appointments where we discuss treatment options and we go over multiple treatment options, what we recommend, and then we have them choose at the end of the day. And most of the time, they will go with the optimal treatment option based on their medical comorbidities.
And then I know you talked about how right now you are being paid, correct?
Yeah.
For OMFS. So if this is too personal, you don't have to answer it, but is it good pay, or is it kind of like you are still in school, I guess you could say?
I would say the pay is better than when I was a research assistant. When I was at the NIH doing a fellowship year, I got paid like, if I can remember, like low 30,000, like maybe 33, 34,000 for a year stipend. And being someone who's really never made that much money, that sounded good to me. So I was able to survive off 34,000 a year, being just doing research full time, where every day I wake up in the NIH campus, I just roll over out of my bed, put my shoes on, and walk to my research building, which is like 300 feet away. That was plenty of money. And then now as a resident, it's based on the average income in the state. And for Alabama, it's lower than, say, New York. So our resident salary is, oh man, I don't want to get it wrong, I think mid-50s. And that's livable for sure. New York, obviously, expensive living is higher. So they get paid high 70s, I believe. So pay is perfectly fine unless you're living in some fancy condo penthouse and going out every night, eating and drinking and stuff. So I would think pay is definitely livable, reasonable, and not putting you in a position where you're figuring out what your next meal is every day. And at the same time, most residencies for oral surgery have some sort of meal plan. At Michigan, they give you, I don't know if it's the same now, but they give you, meal plan credits or money that you can spend every term or whatever in the cafeteria, and then it just rolls over every time. Here at UAB, we get 60% off in the cafe, so that's a pretty darn good deal. You can have a full plate breakfast for like $1 something.
And then our last question for you is, what is your favorite procedure to perform?
Wow. It's a really good question. I would say, since I like head and neck stuff, complex reconstruction. So whether it be, I think complex mandible reconstruction would be good. I think the most challenging about these type of procedures is really finding what type of tools you have in the armamentarium. What are you trained to do? What is available out there? And do you feel competent using it? And what is the best option? So, mandible reconstruction, depending on the location of the mandible, you can use multiple different types of bone. You can use the scapula bone, certain portions of it. You can use the iliac crest, your hip bone. You can use your leg bone. And for really small defects, you can use like your tibia bone, but that's not common. Even do a rib bone for kids. So based on that, it's really unique to really go to a place that can really train you in everything you want to do, and be able to, when you go out and work in the field, be able to have such a broad scope of training that when you're presented with a dilemma or situation, reconstructive challenge, you have many options to go with, because not every patient has good fibula bones. You have vascular disease that prevents good blood supply to these leg bones. And, you can't use the leg bone. If you take it, the foot's going to die, the bone's going to die. But you got a scapula bone, or you got your hip bone that you can use still. So I think that challenging reconstructive surgery is something that I like doing or be a part of.
All right, well, that concludes our questions. Thank you so much for answering all of them. And this will also conclude our session. So thank you so much, Dr. Lay, for coming today and talking to us all about OMFS. We really enjoyed it. The post-session quiz will be linked in our link tree in our bio for you guys to take, and I'll also drop it in the chat. So thank you so much, Dr. Lay.